Okay, we'll get started. Good afternoon, everybody, or good evening, depending on where you are in the country. Today's Good Hormone Health webinar is entitled PMOS, formerly PCOS, What's Behind the New Name Change? Our outline today is why was the disease formerly called polycystic ovarian syndrome, or PCOS, now called polyendocrine metabolic ovarian syndrome, or PMOS? How is that consistent with my approach to the condition? How is PMOS diagnosed? What labs are needed to diagnose and follow PMOS? What medicines can be used for PMOS? Is there a PMOS diet? What supplements can be used for PMOS? And what is Symetra, and why is it appropriate for PMOS? So PMS is common. Some of the slides do still have the old term of PCOS on it, but they are somewhat interchangeable. Doctors that understand it are not that common. It's thought that sort of 1 out of 8 women in the United States have PCOS or PMOS, and many of them, about 70%, are underdiagnosed or not diagnosed. Um, and there's more than 7 million women. That's more than the number of people diagnosed with breast cancer, rheumatoid arthritis, multiple sclerosis, and lupus combined. PMOS is a hormone imbalance in women that affects about 1 in 8 women. PMOS probably has several etiologies: ovarian, adrenal, pituitary, hypothalamus. This is what I learned when I was a fellow at the NIH in the 90s, and I still think it's true, and has gradients from mild to severe. PMOS is part of the metabolic syndrome, which includes insulin resistance, abnormal lipid measurements, obesity, high blood pressure, acne, facial hair, infertility, male pattern balding, and difficulty in losing weight. So this is a picture, again, some of this older pictures that uses PCOS, whether we're using PMS now. Head, dandruff, male pattern baldness, depression, extra hair growth, coarse hair growth, masculine features, skin, dry, dark patches, cystic acne, abdomen weight gain, pelvis thickening to the wall of the uterus, polycystic ovaries, multiple cysts, irregular menses, infertility. The causes include the hypothalamus, as I mentioned. It could be a hypothalamic disorder due to increased GnRH. Their LH and FSH are abnormal. Often the LH to FSH ratio is high. This can lead to high insulin levels, insulin resistance, weight gain, skin changes, and fungal infections. The ovaries have abnormalities in the ovaries. The follicles do not mature. You don't get ovulation. This leads to the adrenals making DHEAS, the adrenal hormone, which is underappreciated. And they get increased conversion from estrogen to testosterone, giving you increased acne, facial hair, male pattern baldness, and masculine features. So common signs in PMOS include no periods or irregular periods. Other symptoms include pelvic pain, weight gain, trouble losing weight, acne, thick skin with dark patches. Half of the women with PMS will experience weight gain, and many experience issues with fatigue and difficulty sleeping. Hair loss is quite common. Additionally, many women experience mood changes because of PMOS. In May 2026, there was a consensus process with many stakeholders that they decided to change the name to PMS, which more accurately characterizes the disease's effects on multiple endocrine systems, and to move away from the misleading emphasis on polycystic ovaries, which I've always felt that they weren't really a key part of the syndrome, and many people with PMS did not have polycystic ovaries, so I think it's a good move that they changed the name. Patients with PMS are at a risk of adverse metabolic, reproductive, and long-term cardiovascular health risks, making proper identification and management of PMS essential for improving your health outcomes. Neither biochemical testing nor ultrasonic imaging is required, according to this consensus statement, to make clinical diagnosis of PMS. Although as an endocrinologist, I use frequently laboratory tests, including androgen levels, and I actually think they're essential. The main features of PMS would be, according again to this consensus statement, of ovulatory dysfunction, irregular, infrequent, or absent menstrual bleeding, hyperandrogenism. They can be either clinical or biochemical, but I'm a big advocate of measuring hormones, making sure it's biochemically confirmed. This includes hirsutism, male pattern hair loss, and acne. And then you can have the polycystic ovarian morphology, which is done on ultrasound, or you can have an elevated anti-Müllerian hormone level. And this actually can be used as an alternative. And I think more and more doctors are moving away from the ultrasound and doing more biochemical testing. To diagnose PMOS, you have to exclude other etiologies of androgen excess and/or irregular periods. Most common of these is Cushing's syndrome, and many people do come to see me because of Cushing's syndrome. People can have irregular periods due to prolactinomas. They can be perimenopausal or menopausal, although they usually don't have androgen excess from that. They can have androgen secreting tumors, and they can have congenital adrenal hyperplasia, specifically late onset congenital adrenal hyperplasia that can look very similar to PCOS. And again, the official diagnosis is made by, according to the statement, made by irregular menses and clinical or laboratory evidence of hyperandrogenism with the exclusion of other causes. Is everybody muted on FaceTime, Tiffy?
Yeah.
Okay, good. Adults with irregular menses or hyperandrogenism should get a pelvic ultrasound. If they only have one of them, they can get a pelvic ultrasound, and the diagnosis can be made in general. I work on mostly laboratory evidence, and I don't get pelvic ultrasounds. The endocrinologists like me make the diagnosis primarily based on high androgen levels, testosterone, DHEAS, and I follow them at diagnosis and I use them for treatment. Insulin resistance is important, especially with the PMOS. Gynecologists use the ultrasound more frequently, although again, I think it's becoming less. They look for the string of pearls on the ultrasound. Some gynecologists don't even measure testosterone, although I think that's, again, is changing. I think more and more people are measuring testosterone levels. And PMOS has several etiologies: ovarian, adrenal, pituitary, and hypothalamic, and has gradients from mild to severe. The guidelines don't recommend a pelvic ultrasound except in limited circumstances, especially in women that have either hyperandrogenism or irregular periods, but not both. And you would look for having 20 or more follicles at this 2 to 9 millimeter size. Some of the symptoms we talked about earlier, but these include irregular no periods, facial hair, acne, infertility, can't lose weight, hair loss, and balding. It's very important to recognize that PMOS is part of the metabolic syndrome, which includes insulin resistance, abnormal lipid measurements, obesity, and high blood pressure. It may be harder to lose weight if you have PMOS, but the weight loss and healthy diet are crucial in PMOS. Therefore, it's a difficult disease because you have both inability to lose weight, but you need to lose weight. And PMOS is associated with increased cardiovascular disease, more heart disease is associated, actually, or even a little bit more kidney disease can be associated with it. So this new name change really ties in metabolic syndrome with PMOS. This is always part of my treatment. The treatment should address metabolic issues, including insulin resistance and high testosterone. And we'll talk about my supplement I'm working on, Symetra, is really designed to address the metabolic issues. Some of the long-term health consequences of PMS include hyperinsulinism, insulin resistance, and some people have impaired beta cell function, increased risk for type 2 diabetes, obesity, hyperlipidemia, and general increased cardiovascular risk and the risk of endometrial cancer if you're not having periods. Some of the reproductive impacts includes increased prevalence of menstrual disorders, hyperandrogenism, reduced response to ovulation induction, requirement for a higher dose, making infertility much harder to treat. There's a higher rate of miscarriages and a higher rate of pregnancy complications, including gestational diabetes. So the laboratory test I use to diagnose PMOS is mostly the total and bioavailable testosterone with the SHBG. And I'll talk about why that is so important. DHEAS is high in adrenal PMOS. I usually can get a day 3 LHFSH and estradiol to look at perimenopause. We do Cushing's tests, including 24-hour urinary cortisols and salivary cortisols. I usually measure prolactin level, 17-hydroxyprogesterone. It's screening for congenital adrenal hyperplasia, hemoglobin A1C, fasting insulin, and glucose. And the main test I do is the bioavailable testosterone, SHBG, and DHEAS, and I usually follow them with treatment. Now, the SHBG is a very important hormone, sex hormone binding globulin. It's a protein that binds both testosterone and estradiol. Its amount can vary widely in patients, and the SHBG is either low or high, the amount of active bioavailable testosterone could vary widely. Therefore, it's very important to measure SHBG in all patients being evaluated for the polycystic ovarian syndrome. The assay for free testosterone women is often inaccurate. I used to use that at less. But you can measure the total testosterone SHBG and do the bioavailable testosterone, and it's quite accurate in all the labs, LabCorp, Quest, Esoterics. The bioavailable testosterone includes the free testosterone, but what is loosely bound to albumin is basically what is the active amount of testosterone. This assay for bioavailable testosterone is accurate. It's formed by Quest, LabCorp, and Esoteric. The bioavailable testosterone determines how much active testosterone the patient actually sees. The patient may have a normal testosterone but a low SHBG, and therefore have high bioavailable testosterone. And they may have signs and symptoms of androgen excess, such as hirsutism or acne. The doctors say your testosterone is normal, but it's the bioavailable testosterone that's not normal. On the other hand, the patient may have a high total testosterone and a high SHBG, but a normal bioavailable testosterone, and then they don't have the androgen excess. SHBG is reduced in insulin resistance and obesity, and actually is a good marker for insulin resistance. So patients say, oh, my SHBG is high, and I tell them it's good news. When the SHBG is low, it's more consistent with PCOS. Anyone with PCOS or PMOS have a high normal or even a normal total testosterone, but have a low SHBG because they have insulin resistance. Therefore, the bioavailable testosterone is off on the high side. And I use a cutoff of 7 to diagnose PMOS. If you're above that, I think the PMOS is likely. If you're below that, it's less likely. On the other hand, birth control pills or other forms of oral estrogen raise the SHBG and give a higher total testosterone than FSHBG is normal. These patients often have a normal or low bioavailable testosterone. And a study found that birth control pills can raise SHBG, and even after stopping it for at least a year, the SHBG remains high. Because the SHBG is high, often the bioavailable or active form of testosterone is low. The female patient often has low libido when on estrogen and even being offered for a period of time. And again, it takes a while for this to return to normal. SHBG is not affected by transdermal estrogens such as estrogel or oral estradiol patch. It appears that progesterone such as prometrium or proverum may also raise the SHBG slightly, but this is usually to a lesser extent than oral estrogen. So I'm always having my patient trying to figure out what they have wrong with them. Is it hypopituitarism with growth hormone deficiency, polycystic PMOS, or Cushing syndrome? PMOS and Cushing syndrome can both have acne and hirsutism. However, the testosterone is high in the PMOS syndrome, especially the bioavailable testosterone. What's usually low in Cushing syndrome or hypopituitarism. I published a paper about 15 years ago or so looking at testosterone levels above 31, then esoterics is more indicative of PMOS, and less than that is more indicative of Cushing's disease. A very high testosterone greater than 100 or a DHEAS level greater than 500 could indicate in either an ovarian or adrenal tumor and worthy of an ovarian ultrasound or an adrenal CT or MRI. Other hormones that are helpful, the high LH-FSH ratio is often seen in PMOS. It's often higher than 3.3 to 1. Estradiol can be low, normal, or high in PMOS. High LH and FSH and low estradiol are consistent with perimenopause or menopause. High prolactin is consistent with prolactinoma. High 17-hydroxyprogesterone is seen in congenital adrenal hyperplasia. And high DHEAS is usually high in PMOS and doesn't require any additional workup. It doesn't require looking for congenital adrenal hyperplasia with that DHEAS elevated. And usually just requires treatment to lower it. Okay, and then DHEAS versus testosterone. DHEAS is the adrenal androgen that is often high in PMOS. Glucocorticoids like dexamethasone can, in theory, lower DHEAS, but they have too many side effects for use. Prescription medicines are really not that effective at lowering DHEAS. So the supplements are quite good. We'll talk about the medicines and the supplements shortly, but I think it's very important to recognize this role of DHEAS, and many providers don't recognize that, and it's a culprit in PMOS as well as the testosterone. Okay, so what are some of the treatments for PMOS? The first one is birth control pills. The Endocrine Society recommends birth control pills as a first-line treatment for PMOS. The advantage of birth control pills is lowers bioavailable testosterone by lowering LH and FSH. It raises the SHBG, so the bioavailable testosterone is lower. Total testosterone is high, but it also doesn't matter. And you usually have a regular period. It helps prevent endometrial buildup and helps prevent uterine cancer. And I would say it's a good choice in a young woman who wants contraception. Um, but it does not have a good choice in an older woman, a woman that wants to get pregnant. The disadvantage of birth control pills is they don't improve insulin resistance. They can lead to weight gain. It's hard to follow the course of PMOS as you were originally looking for whether the period would return on its own, and then you're giving birth control pills. And so it really sort of masks the underlying cause, which is the insulin resistance and elevated testosterone. Birth control pills affect various liver functions, including the SHBG, cortisol binding globulin, and thyroid binding globulin. So a lot of patients on birth control pills have a very high cortisol. They think they have Cushing's, but it's really because their cortisol binding globulin is elevated, raising their total cortisol, but not the free cortisol. Some birth control pills have a lot of androgenic properties, which means they act like testosterone. Birth control pills lower estrogen, and these women with PMOS are often low in estrogen. And this may lead to menopausal-like symptoms. Birth control pills can affect factors that can lead to blood clotting. So I think as a woman gets older, I'm less reluctant to give birth control pills. Birth control pills lower IGF-1, which makes a patient growth hormone deficient, which a lot of my patients are. We're trying to treat them with growth hormone. And then birth control pills, you can't try to conceive. So if you're trying to conceive, doesn't make any sense to take birth control pills. Some reproductive endocrinologists try to manipulate the system a little bit, and they give it first to raise the SHBG and then stop it. But it's very tricky to do that. I think it's better if somebody's trying to conceive to give them something else. The next treatment for PMOS is metformin. Metformin improves insulin resistance, helps with weight loss, but only a little bit, helps prevent several types of cancers. It lowers testosterone and DHEAS a bit, but not that much. Disadvantage is it doesn't work too well. It has a lot of GI side effects, including nauseousness, bloating, gas, and diarrhea. If you take a low-carb diet or you take the metformin extended release, side effects are often less. Can lead to B12 deficiency. The typical dose I use is 500 to 1,000 milligrams twice a day. For the metformin, you can work up a little bit on the dose. Another medicine I use frequently for PMOS is spironolactone. It lowers testosterone. It also blocks aldosterone. It also blocks testosterone. So it decreases both the secretion and blocks the receptor. So you get sort of a double effect. It blocks aldosterone, so it's also a diuretic. It helps with heart and kidney disease. It works pretty well. The disadvantage is it blocks aldosterone. So somebody with low blood pressure, they can get worse, get dizzy on standing, dehydrated. It can raise potassium. This usually doesn't happen in younger people. It does happen a lot in older people or with also kidney disease or diabetes. It rarely raises liver tests that are reversible. I like to sort of keep an eye on the liver test every 3 months. You should not take while pregnant, but you can take up until pregnancy. It's not that dangerous to take if you get pregnant, but you should try to stop it. Typical dose is 50 milligrams twice a day. The older patient, I would probably use less. And a younger person, you can go up to 100 milligrams twice a day. Another medicine I like a lot for PMOS is called Casodex. It blocks testosterone. It's a very potent drug. It lowers testosterone, blocks testosterone at the receptor, decreases hair growth very well. It only blocks testosterone at the receptor. It doesn't block aldosterone, unlike spironolactone, so it doesn't give you the low blood pressure. The disadvantage is it's a prostate cancer medicine, so you're using it off-label. It's not FDA approved for women, which isn't that big of a deal. Doctors are allowed to prescribe things off-label. It rarely reversibly raises liver tests, so you do need to monitor liver tests every 3 months. If you do get elevated liver tests, you can stop it. You should not get pregnant when taking it. And this is a little bit more dangerous in terms of conception than the spironolactone. So I think you should surely stop it if you get pregnant. If you're trying to conceive, you're close to conceiving, you might want to stop it. Typical dose is 50 milligrams a day and up to 50 milligrams 3 times a day. Another medicine I use a lot for PMS is progesterone. It lowers testosterone due to feedback. If you give it every 11 days a month, like days 15 to 25 of the month, you can often restore periods. It's good for women to put on birth control pills who want to get off. It has much less side effects. It's bioidentical compared to birth control pills. Occasionally you get fatigue. I usually give it at night, weight gain and bloating, but not too often. I prefer the bioidentical progesterone. The brand is called Prometrium over synthetic Provera. The Provera, I just think it's not bioidentical, doesn't work as well. I would typically give progesterone 200 milligrams at bedtime, days 15 to 25 your cycle, if you want to, especially if you want to restore your cycle. And you can also give it continuously if the patient doesn't want to have a cycle. Another surprisingly good medicine for PMS are statins. So these are medicines used to lower cholesterol, and that's the advantage. They also lower cholesterol, but they have a good side effect profile. They lower testosterone also quite well. These are usually pretty well tolerated. Occasionally, people get muscle aches. Rarely, you get decreased memory. In general, studies have found that they actually help prevent Alzheimer's disease. There's a slight increase in glycemic parameters like hemoglobin A1C, but it's very insignificant. So I use these a lot. A typical dose might be Lipitor 40 milligrams at bedtime or Crestor 20 milligrams at bedtime. The next category of medicines that is quite helpful for PMS are the GLP-1 receptor agonists. These are medicines, semaglutide and tirzepatide. They lower testosterone. They are often expensive and may not be covered by insurance unless you have diabetes. And they aren't covered for PMS right now at all. And so, you can't even put a PA in for trying to get around PMS. They won't be covered. I often use compounded GLP-1s, tirzepatide, and semaglutide for weight loss. They're especially helpful for PMOS, especially the metabolic component. Advantages of them are they lower testosterone, they give you weight loss, they improve diabetes parameters. Disadvantages, they can be expensive, not covered by insurance. The compounded ones are less expensive, but they're more expensive than metformin, say. Side effects include nauseous vomiting, abdominal pain, loss of appetite, diarrhea, constipation. A typical dose I would use would be compounded tirzepatide, maybe 2.5 milligrams weekly. You can do microdosing and start with a low dose or work your way up if needed. So to summarize treatment for PMOS, you often need to use more than one drug. The drugs may have side effects. And this points to a need for dietary interventions and supplementary interventions. So what is a healthy PMOS diet? So first of all, you want to do anti-inflammatory diet. Ultra-processed foods, especially high-carb foods, high amounts of carbohydrates trigger insulin release, and trigger inflammation. These include cereals, white bread, white rice, baked goods, crackers, cookies, sodas, soft drinks, fruit drinks. All those can lead to inflammation, lead to insulin release. I like this slide. I show this to my obesity patients. You have your corn on the cusp, and a corn in a husk. It's minimally processed. The corn in the can is a little bit processed. It's corn cut up. It's basically still corn. The Doritos have a little bit of corn in them, but not too much. It's mostly chemicals and fiber and fillers. They don't have any fiber in them. They don't have any nutrition in them. They have a lot of salt, additives, flavorings, and the grocery stores are filled with these type of foods. 7-Eleven's full of them. So really try to cut down these ultra processed foods. I would say would be the main sort of diet recommendation for PMOS. So try to have foods containing healthier carbohydrates, whole grains, fruits, vegetables. I like having 2 servings of vegetables per meal. You can have both starchy and non-starchy vegetables. The non-starchy ones are really good for you. Even the starchy ones like peas and beans are probably fairly good for you. Legumes are good. So concentrate on these type of foods. So basically, for a healthy PMOS diet, no sodas or fruit drinks. Start the day with a high protein or vegetable breakfast. Eat regular meals and some snacks throughout the day. Don't eat too much. Include protein, fat, and some carbs at each meal. I usually recommend mostly vegetables at each meal with a little bit of these others. Focus on unprocessed whole foods. Include a rainbow of fruits and vegetables. 3/4 of your plate should be fruits and vegetables, grains, starchy vegetables, beans and lentils, things like yogurt and milk are okay to add. And keep your carbs to 1/4 of your plate. So this is a plate I showed my patients, a lot of fruits and vegetables on the left side, the plant proteins, some whole grains, so a little teeny bit of plant fats are okay. This would be what I would recommend for a PMOS diet. Okay, and then we'll talk about supplements to conclude with. So why take supplements? So the supplements are often quite effective. They improve the labs. They help you for insulin. They help your cholesterol, triglycerides. They improve ovulation. Many of these have been studied extensively. double-blind studies. They improve the egg quality. They lower testosterone, especially they lower DHEAS, which is hard to do with some of the medicines. They help deficiencies in your diet. If you have malabsorption, you have gastric bypass, you may have low levels of some of these hormones, some of these vitamins. And people that are vegan don't get enough B12, so it's important maybe to supplement that. And it's important to optimize your nutrient levels. In general, I advocate, a balanced diet and try to get most of your nutrients from food. But some people may need to add some of these supplements, and these supplements can be used to lower your testosterone levels, for example, DHEAS levels. So metformin can give you low B12 levels. It's quite common. It's progressive. It depends, the dose response. And you can get macrocytic anemia, neuropathy, nerve damage, mental changes. And I like to keep the level of B12 above 400. It's a simple medicine to take. You don't have to do fancy tests. And I'd say patients on metformin should get their B12 level at least twice a year, maybe more. You want to keep, again, the level above 400. There's these Amazon B12 gummies that are 2 gummies for 3,000 micrograms. So you can take 1 gummy. It's easy to take and cheap. Tastes pretty good. Usually 1,000 micrograms a day is a good choice. So there's several studies on this. A study in PLS1 showed the higher the dose of metformin, the more deficient in B12 people are. And it's the same in people with type 2 diabetes and PMOS. And this can lead to low levels of B12, both long-term and short-term. In some women taking metformin, it lowers B12 levels in patients with PMOS. This study was in 2013. So definitely looking at your B12 level and replacing it would be a good choice. Now, these two supplements are very helpful for PMOS, myo-inositol and D-chiroinositol. These are relatives of B-complex vitamins. They're found in foods, fruit, beans, cereals, buckwheat. The inositol phosphoglycan, IPG, are secondary messengers, and they regulate activities of hormones, including FSH and insulin. They're quite useful in insulin resistance. They can help with lipid issues, and they lower your androgens. They help with infertility. They help with high blood pressure. They lead to a little bit of weight loss. Can everybody mute themselves? They reduce gestational diabetes risk, improve egg quality, and lower your TPO antibodies. So they have quite a lot, which is in Hashimoto's. I recommend 2,000 milligrams of myo and 50 nanograms of DCI as 40-to-1 ratio. And I recommend taking it with meals. I like this brand, Omnibiotics, on Amazon, myo-inositol plus, and this is going to be the main ingredient in Symetra. Side effects would be hypoglycemia. Here's a study in European Review of Medical Pharmaceutical Sciences in 2009, randomized controlled trial, increased insulin sensitivity, decreased triglycerides, decreased cholesterol, decreased testosterone. Testosterone was almost cut in half. It's quite impressive. In fact, decreased systolic and diastolic blood pressure, and 69% of the women started ovulating. Another study by also in European Review of Medical Pharmacological Science in 2007 showed mine also improved ovulation compared to control, simply increased HDL, your good cholesterol, reduced your body weight, and 70% of women established a normal ovarian circadian rhythm. So these are quite helpful. Mine also improves egg quality better than DCI. It's important to have a good ratio of them. There was one study, again, European Review of Medical Pharmacological Science, that showed myo-inositol is more effective than D-chiroinositol. And taking too high of a DCI dose made actually your egg reserve worse. So it's important to do a good ratio of the myo-inositol to DCI. Another supplement that's very good for PMOS is NAC and acetylcysteine. It's an antioxidant and an amino acid. It's a derivative of L-cysteine, a precursor to glutathione. Its advantages are improves insulin resistance, infertility, dyslipidemia, inflammation, androgen lowering. It helps with oxidative stress, helps with bronchitis, and its immune support. It's fairly expensive, And there are other things that have a similar name, so you need to make sure you're getting the N-acetylcysteine and not something else. It's also hard to sort of put in supplements, so it's not going to be in Symmetra, but you can get it separately. Sort of a dose of about 3 grams is needed to be effective. There's NAC from Now on Amazon that's quite good, and it has GI issues and fatigue as its side effects. There's 8 randomized trials with 910 women, and general NAC improved BMI, total testosterone, insulin, lipid levels that had improved in rates of pregnancy and improved ovulation risk rate compared to placebo. And it was as good as metformin for improving pregnancy rates, spontaneous ovulations, menstrual irregularities, insulin resistance, and cholesterol. Resveratrol is what's in red wine. It's found in grapes, berries, and peanuts also. It's an antioxidant, anti-aging, anti-cancer, and has cardioprotective properties. So it really is an excellent supplement to take. 30 patients with PMOS were randomly given either resveratrol or placebo. The resveratrol group had a 23% reduction in their total testosterone, 22% reduction in their DHEAS. The fasting insulin levels dropped. The advantages are it does reduce total testosterone levels and DHEAS levels. And disadvantages are some GI side effects of it, but not too much. I often recommend Doctor's Best Trans Resveratrol or Nutravine Premium Resveratrol. Fish oil is another good supplement. It reduces inflammation, helps with depression, supports healthy pregnancies, improves triglyceride levels, helps with fatty liver disease, fertility, sex, skin and hair health. It probably helps with dementia. There's little disadvantages. Sometimes it smells fishy, depending on the brand you get. But in general, it's a reasonably safe and good supplement. You have to check the milligrams. You do want to take at least 1,000 milligrams a day, preferably twice a day. Nature's Bounty fish oil has 1,000 milligrams, and there's Nature Made fish oil with 1,200 milligrams. Berberine is another medicine that I supplement. I use a lot. It's a Chinese herb, and the dose is usually 600 milligrams twice a day. It's very good for prediabetes and diabetes. It was found to reduce testosterone, lipids, insulin levels, and gave weight loss and improved fertility. It reduces testosterone, lipid, and insulin levels, and it gives weight loss, improves fertility, and reduces fatty liver. There's some nauseousness and constipation. Reasonable brands would be Premium Berberine HCl by Smart Nutrilabs and Toplix Berberine Supplements. And you have to be careful. The bottle usually says 1,200 to 1,800 milligrams is the dose, but that's for 2 or 3 pills. Each pill is usually 600 milligrams. They usually recommend 600 milligrams twice a day. There was a 2022 prospective randomized controlled trial with women with PMOS looking at myo-inositol, berberine, and metformin. All groups improved cholesterol and triglycerides, but berberine showed the greatest benefit, leading to larger decreases in total cholesterol, LDL, and triglycerides, the biggest increase in HDL compared to metformin and myo-inositol. All treatments reduced weight and BMI, but berberine led to the largest drop in waist size and waist to hip ratio, showing a stronger effect on central weight loss than metformin and myo-inositol. And these findings suggest that berberine may be a great option for women with PMOS that are focused on cardiovascular health and weight loss. Probiotics are another option. Probiotics improve insulin sensitivity and glucose control. They help decrease fasting insulin and glucose levels and improve your HOMA-IR score, which is insulin resistance. They lead to a significant increase in SHBG and decrease in total testosterone levels, and the free androgen index, which reduce symptoms like hirsutism and acne. They reduce inflammation. PMOS is associated with low-grade inflammation. Probiotics can lower inflammatory markers like highly sensitive CRP. Probiotics may help manage cholesterol and triglyceride levels, helping reduce the cardiovascular risk associated with PMOS. While it's not a direct weight loss tool, they have been associated with modest weight loss, weight reduction, improved body composition when combined with dietary and lifestyle modifications. I think the best PMOS supplement is Akkermansia, and you can take 1 pill a day. Vitamin D has also been found to be helpful. This dose had 100,000 units a month in a couple of journals, Complementary Therapeutic Practice, and the Taiwanese Journal of Obstetrics and Gynecology. They found that vitamin D improved follicles, helped with menstrual regularity, and the vitamin D plus metformin was better than metformin alone. Infertile women with PMOS who underwent clomid stimulation had more follicles and were more likely to get pregnant when they had higher vitamin D levels. And in vitamin D deficient women, vitamin D supplementation lowers the abnormally elevated AMH levels, which is probably a helpful thing, but may or may not be. So this leads us to Symetra. Symetra is a blend of supplements that separately have been shown to improve PMOS. This is going to be available shortly. We just got the final product. We're working on the label now. It's a powder. The flavor is called mixed berry and contains myo-inositol, D-chiroinositol, resveratrol, Akkermansia mucinophilia, the probiotic, B6, selenium, zinc, and chromium. It does not contain NAC and it does not contain berberine because they didn't taste good and we couldn't really get the dose in them. So people can get those separately. It's gluten-free, soy-free, dairy-free. It's called NLEA, which means all the ingredients listed are present. I recommend 1 scoop for PMOS and 2 scoops for more severe PMOS. I think it's likely to be better than any supplement on the market. We expect it to be available in a couple months, but we're going to use the website symetrapmos.com, reflecting this new name change. This is what the label is going to look like. Again, it's going to be 1 scoop, 30 servings per scoop. I think we're going to charge around $49 for it. And it has the B6, zinc, selenium, chromium, myo-inositol, resveratrol, Akkermansia mucinophilia, and D-chiroinositol. So the label cannot, according to the FDA, say it's used to treat PMOS or PCOS. So we're trying to figure out how the best way to get around it. This is what we came up with so far, but we may change it a little bit. Symetra is a doctor-formulated dietary supplement designed to support healthy hormone balance and metabolic wellness. It contains a blend of nutrients and probiotics selected to help maintain normal endocrine function and overall reproductive health. Women may use Symetra to support healthy androgen metabolism, balanced ovarian and adrenal hormone activity, metabolic health and healthy glucose processing, and overall reproductive system wellness. So overall, I think I have a unique approach to PMOS, combining medicine, supplements, and diets. I think there's rarely you can find a provider that does all those. And some people do supplements, some people do medicines, some people do the diet, but I think I uniquely combine all of them. If you're struggling with PMOS, and again, I think it's a hard disease to treat, it's misdiagnosed and mistreated, please make an appointment to see me at goodhormonehealth.com. Spironolactone, progesterone, Casodex, GLP-1s are all good options, often together. Anti-inflammatory foods, sensible portions, and low carbs helps. Supplements, when added to a healthy diet and lifestyle, can offer health benefits and aid in improving ovulation. I think Symetra will be a likely breakthrough in the treatment. In the meantime, there'll be, I have my PMOS article on goodhormonehealth.com. If it's an excellent article, it has links, and you can get your supplements on Amazon separately. So this will be posted in a couple of days. It'll be available on my YouTube channel, Spotify, podcast channels. It's available on Facebook. If you have any questions, please let us know.
All right. Thank you, Dr. Friedman. Can start with some Facebook questions and get into the Zoom questions. I have one girl ask, is there a benefit from taking both NAC and MYO, or is that overkill?
No, there's a benefit. They are synergistic. Both of them are helpful. In general, I recommend 6 supplements if you can afford them and tolerate them. They're not that expensive. But the myo-inositol, D-chiroinositol, which is called myo-inositol plus, and then resveratrol, NAC, omega-3s, probiotics, and berberine are all good choices, and you can combine them together.
Okay, a follow-up to that. Do you have a favorite PMOS birth control for those that want to do contraception?
Yeah. Mm-hmm.
And what, okay, I guess you could answer that first.
Right. So there used to be one called Desigen. I think it's harder to get. It may not be available. That had a low androgen level. I think Yaz and Yasmin are good choices. And then they have these progesterone-only ones, such as Slind, which is called norethindrone. They work okay, but they're low. They don't have any estrogen in them, so you're sort of blocking your own estrogen.
What level of DHEA might you be concerned of adrenal etiology rather than PMOS?
Yeah, so I would still say PMOS is adrenal also. So I wouldn't say it's a separate disease. You have an adrenal variant and ovarian variant. And, now the term doesn't have ovarian in it really. So, it's a metabolic condition. But in general, if the DHEAS is above the range for the age, I'm more concerned it's really an adrenal etiology, especially if the testosterone is more normal, the viable testosterone is more normal.
All right. Thanks for your presentation, Dr. Freeman. You talk so fast. Can you post this so I can read later? We speak
Of
slowly in
course.
Texas. Don't worry, we're going to post it.
Yeah.
Okay. Um, why would someone with stage 4 endometriosis develop hirsutism,
Narcissism.
acne filled fluid cysts that had been drained before suspicion of adrenal insufficiency and later develop a hemorrhagic endometriosis, gosh, that's a lot, and ovarian cyst after diagnosed polyendocrine cortisols monitored and later diagnosed with adrenal insufficiency. Menstrual cycles were stopped before and after suspicion of adrenal insufficiency despite severe endometriosis. Menstrual cycles always on time. Is this related to PMOS? I was emaciated and 82 pounds.
So again, it's a sort of a long question. In general, endometriosis is a separate condition. It's usually dealt with by your gynecologist. It's usually due to ectopic uterine tissue outside of the uterus, and it's very hard to treat. So I would see a gynecologist or a specialist for that. People with PMOS can also have endometriosis. It should be addressed similarly. Most people with PMS are overweight, but not all of them. Some of them could be quite thin. And I would work on optimizing your DHEAS and testosterone hormones.
Mhm. How common is it to have all three? PMOS, AGHD, and Cushing's disease.
They are again separate conditions that you can have all three of them. I did my paper that we looked at the androgen levels in general in Cushing's versus PMOS. And PMOS, the androgen levels are higher, and in Cushing's are lower often. But you could have all of them have them all together.
Okay. Another question from Facebook. Is PCOS, PMOS a disease that lasts a lifetime or is it curable?
So I would say it's treatable, and losing weight, eating healthy, taking supplements can often reverse it. Also, usually women as they age, they go through menopause, their testosterone levels decline. So it can also be cured because people can sort of age out of it. It's usually a condition in 15 to 45 or 50 or so. So people can age out of it.
Okay, and then a follow-up on your birth control slides. Do you think taking birth control makes getting PMOS more likely?
No, birth control pills does help treat PMOS. It does help lower your testosterone, raise your SHBG. Low SHBG is one of the issues. It lowers your bioavailable testosterone, raising your total. So it doesn't make it worse, but can have side effects, and it can be used as an effective treatment for PMOS.
Mm-hmm. Okay, I am menopause now with stage 4 endometriosis, and endometriosis flares up despite of menopause. And I was told this is the pituitary signaling and happens in women with severe endometriosis. How does this happen?
Yeah, so I'm not familiar with showing that endometriosis is a pituitary condition. It's usually due to sort of these ectopic uterine tissues in the places outside the uterus, and it's usually treated with by gynecologists, often surgically. And it's a separate condition.
Okay. Another Facebook question. Women can live with PMOS and not be aware of it?
Hang on 1 second. Sorry. Women can have PMS and be not aware of it, is true. They usually have symptoms of androgen excess, facial hair acne, the inability to lose weight, irregular periods. Um,
Do you think taking supplements like are a good preventative cause or not necessarily?
yes, so I think if you are sort of borderline high androgens, you don't have enough to need a medicine, I think the supplements are very helpful for that.
Does having thyroid problems correlate to having something like PMOS or not necessarily?
No, not necessarily. I would say they're two different conditions.
Okay. Did you create Symetra to help your patients?
Yes, of course. And
Uh,
it's difficult for them to buy the 4 or 6 different supplements. They're not sure which ones to get. So I did want to put them all in one container and wanted to blend them properly and added some different vitamins to it. So I do think it's going to be a very helpful product.
right. And a good flavor, and you'll be able to
Hmm.
take everything at once. So it'll be much more
Right,
simple
right,
and effective. Yep.
right.
Let's see, anything else? If anyone has any more questions on Facebook or Zoom, you can list them now. Someone might want to ask something.
Saul had a question.
Yeah, I'm not sure what it is. Is it typical for people to get PMO or be aware of their PMOS when they're trying to be fertile?
Yes. So one of the main symptoms of PMOS is infertility. And
Why
that's
would
often sometimes people get diagnosed the first time. They're trying to get pregnant and then they can't. And then their doctor measures a AMH level and it's high, not low. And they measure the testosterone level and it's high.
do doctors usually measure that without you asking?
Infertility doctors do.
Yeah.
Maybe gynecologists might.
Mhm. But not a regular just
No.
appointment. Okay. Why would SHBG be low with biotests under 7?
Um, so SHBG is low in PMOS. It's a marker of insulin resistance. And you can have low SHBG and your bioavailable testosterone doesn't have to be elevated. It still indicates that you have some insulin resistance going on.
Mhm. Okay, I was wondering for lean PMOS, is it still metabolical even though all markers are within normal range?
Yes, so to have PMOS, you do have to have either androgen excess or irregular periods, basically. Um, and you can have sort of mild condition. Your periods can be irregular and your hormones can be okay. Most of my patients have the elevated bioavailable testosterone or a high elevated DHEAS level, even if they're lean.
Mhm. Great, just a nice comment. Thank you, Dr. Freeman, for your very informative Zooms and sharing this
Sure.
information with your patients and others. Many of us are learning so much from you. You may never retire.
Thank you so much.
How can PMOS cause low AMH?
It does. It usually causes high AMH, not low. You can have the older, you have poor A quality, and that can give you a low AMH. But in general, for younger people, AMH is usually high in PMOS.
Mhm. What causes low AMH at a young age?
Poor A quality. And
For what?
it's just poor A quality. And it's a statistical thing. Not everybody that has a poor low AMH is going to not be able to get pregnant, but you're less likely to get pregnant if your AMH is low. So if you do have a low AMH, and you want to get pregnant, you should probably see a reproductive endocrinologist.
Right. I know that this is probably another reproductive question, but on Facebook, they said, do you think taking birth control lowers your chance in getting pregnant and higher your chance in PMOS? I know you kind of answered that.
So it's very hard to get pregnant if you're on birth control pills. Again, some reproductive endocrinologists put people on
But
birth control
I think
pills,
she's
and
meaning like having. I think she's meaning like having it in your system for however many years.
probably not.
Yeah.
And then you could stop it, and some reproductive endocrinologists can should try to get you pregnant.
Uh-huh. I get, and another question from Facebook is, um, besides the symptoms you listed, what are a reason that someone would get PMOS?
It's genetic. I think a lot of it is women have it, their mothers have it, their grandmothers have it. A lot of it's genetic. I don't think we know all the genes involved, but it seems to be somewhat genetic,
Mhm.
somewhat related to poor eating poorly, but not too often.
Mhm.
Obesity makes it more likely.
Okay. All right, great. I think we have couple more questions and we'll call it a day. If I have PMOS, when should I be helping my daughters / looking for it in them?
Yeah, so I think if they're not having, I don't know how old your daughters are, but if they're not having periods, and they're having facial hair acne, I think they should be tested also.
And you can get tested at any age.
Yeah, any age, sort of above puberty.
Right. And you just ask your doctor, what kind of test do you
Well,
ask them?
I think I would probably, you could ask your pediatrician, but I would
Uh-huh.
start with um, the bioavailable testosterone DHEAS levels.
Okay. Um, she asked, do you see preteens?
Usually not. You should just start seeing people in puberty. It's not a really disease of preteens. It's mostly once they start having, they're supposed to
Period.
start having periods.
Right. You wouldn't really be diagnosed with something like that before that.
Mhm.
Do twins have higher prevalence of PMOS?
No, if one twin has it, the other does, but
Oh,
separately not.
well, they both have to be girls.
Right. Okay, so let's call it a
Okay.
day. Thank you guys so much. It was really
Thank you,
interesting.
everybody. Yeah,
Again,
great
we'll post this
talk.
very shortly.